Namaskar and welcome everyone to this first lecture of this course on rehabilitation of sports injuries of the knee. I am Colonel Rishikesh Pandey. I am an orthopedic surgeon and presently the professor and head of Department of Sports Medicine at Armed Forces Medical College, Pune. In this lecture, I am going to take you through to the basic journey of anatomy and functioning of the knee. In this lecture, I am going to take you through the basic anatomy and functioning of the knee. The knee is the largest and the most complex synovial joint in the human body. It is also one of the most frequently injured joints, particularly in athletes and active individuals. It plays important role in locomotion, posture, and weight bearing. It has a fine balance between stability and mobility, and this is essential for daily activities and athletic performance. Although primarily a hinge joint, it allows small degree of rotatory motion, which is critical for smooth and efficient movement. Structurally, the knee is composed of bones, extra-articular structures, and intra-articular structures. Though the ligament play a major role in the stabilization during its various functions, they alone are not sufficient, and the stability of the knee is achieved through combination of action of ligaments, muscles, bones, and neuromuscular control. With this brief introduction, let's explore the anatomy of the knee, beginning with the osteology of the knee. The knee is formed by the articulation of three bones: the femur, tibia, and the patella. The articular surfaces of these three bones are covered by hyaline cartilage. The distal femur has two condyles, the medial and the lateral condyle, and these condyles are separated by a intercondylar notch. The condyles articulate with the median and lateral tibial plateaus and form the tibiofemoral joint. And these joints give rise to the medial and lateral compartment of the knee. The joint is responsible for weight transmission, and between the plateaus of the tibia, where lies the medial and lateral spines, are located the attachments of the ligaments, specifically the cruciate ligaments, and the menisci. The medial plateau is concave and larger in shape, while the lateral is relatively flat or convex in shape. The third bone which forms the part of this knee is patella, which is the largest sesamoid bone of the body, and it is embedded in the quadriceps tendon. It is attached to the proximal tibia through the patellar tendon. It articulates with the femoral trochlea, which has a medial and lateral ridge, the lateral being taller, and this forms the patellofemoral joint. The joint is responsible for improving the efficiency of quadriceps pull in extending the knee. Having seen the anatomy, let's now move on to the soft tissue components of the knee. The joint per se is covered all around by the joint capsule and the synovial membrane. This protects the joint and nourishes the joint by secreting the joint fluid. One of the most important and frequently injured structures of the knee are the menisci, which are crescent-shaped fibrocartilaginous structures situated between the femoral and the tibial plateaus and are completely intra-articular. They have an anterior and a posterior root which is firmly attached to the tibia. If you look at the upper surface of tibia, in the region between the two plateaus is the arrangement of attachment from anterior to posterior various structures. The anterior root of the meniscus, medial meniscus, followed by attachment of the ACL, followed by the anterior root of lateral meniscus, then the posterior root of the lateral meniscus, followed by the posterior root of medial meniscus, and finally the PCL. The region of menisci between the roots or the horn is the body. The medial meniscus is larger, C-shaped and less mobile of the two, since it is attached to the medial collateral ligament and the joint capsule. The lateral meniscus is smaller, it's circular or O in shape, and is more mobile, since it is not attached to the lateral collateral ligament. This makes it less prone to injury than the medial meniscus. The vascularity of the meniscus is derived from the periphery. The characteristic blood supply divides the width of the menisci into three zones. The peripheral red zone, which is the most vascular, then the middle red-white zone, which is intermediate in vascularity, and the innermost white zone, which is almost avascular. Hence, the tears in this zone do not heal well. The functions of the menisci are: they increase the joint congruence by conforming to the curvature of the condyles. They absorb the shock during loading of the knee. They help in load distribution across the bony surface, and they help in proprioception or the joint position sense. Next, we move on to the ligamentous supports of the knee, which are critical for the knee stability. The ligaments of the knee can be either extraarticular or intraarticular. The extraarticular or extracapsular ones are located outside the knee joint capsule, and these are the MCL or the medial collateral ligament, the lateral collateral ligament, the patellar ligament, the oblique popliteal ligament, and the arcuate ligament complex. The medial collateral ligament is a broad, flat ligament attached to the medial femoral epicondyle proximally and the medial surface of proximal tibia distally. It also attaches to the medial meniscus. Its chief function is to resist valgus stress to the knee. The lateral collateral ligament, which is cord-like, attaches proximally to the lateral femoral epicondyle and distally to the fibular head. It resists varus stress on the knee. The patellar ligament is the continuation of quadriceps tendon and attaches this to the distal pole of patella. It attaches the distal pole of patella to the tibial tuberosity. Other extraarticular ligaments like the oblique popliteal ligament and arcuate ligament complex, which support the posterior and posterolateral corner of the knee. Now coming to the intracapsular or the intraarticular ligaments of the knee, these are the cruciate ligaments, which are the anterior cruciate ligament and the posterior cruciate ligament. The anterior cruciate ligament runs anterior to posterior from its attachment to tibia to the inner aspect of the lateral femoral condyle. It resists anterior translation and also some rotational loads. It has two bundles, the anteromedial bundle and the posterolateral bundle. Though they are fused, they cannot be separated during the surgery. The posterior cruciate ligament runs from posterior to anterior and the posterior proximal from the posterior proximal tibia to the inner aspect of the medial femoral condyle. It is the strongest ligament of the knee and has two bundles, anterolateral and the posteromedial bundle. This ligament resists posterior translation of tibia at all positions of knee and stabilizes the flexed knee. It also has a role in restraining tibial rotation when the knee is flexed. The PCL is twice as thick as ACL. Hence, this is less prone to injury due to its stronger nature. In addition to these injuries, the knee stability and function rely heavily on surrounding muscles. So now, let's see the arrangement of various muscles around the knee. Anteriorly, there are the extensors of the knee, which are formed by the quadriceps group of muscles. The quadriceps comprises of four muscles: the rectus femoris, vastus medialis, vastus lateralis, and vastus intermedius. Of these, the vastus medius obliquus is particularly important for patellar stabilization. The quadriceps converge on the superior pole of patella and through the patellar tendon. The extensors are attached to the tibial tuberosity. The quadriceps assist PCL by resisting posterior translation of tibia. Posterior to the thigh are the flexors of the knee, and these are the hamstrings. The lateral hamstring is comprised of biceps femoris, and medially there are three muscles: semimembranosus, semitendinosus, and gracilis. All of these flex the knee, and they also assist the ACL by resisting anterior translation of tibia. Additionally, the semimembranosus, semitendinosus, gracilis, and sartorius and popliteus also act as a medial rotator of tibia when the knee is flexed and resist valgus strain, aiding the medial collateral ligament. The biceps femoris acts as an external rotator of tibia in a flexed knee and resists varus strain on the knee, aiding the function of the lateral collateral ligament. Other posterior muscles is popliteus, which has a role in unlocking the knee during the flexion. The gastrocnemius and the plantaris also cross the knee, assisting the flexion and resist posterior translation of tibia, hence assisting the PCL function. Essentially, the ligaments provide static stability, whereas the muscles are responsible for dynamic stability of the knee. It is pertinent to mention that the blood supply and nerve supply of the knee is also important before we dwell upon the functional aspects. The vascular supply is by the genicular anastomosis around the knee, which provides a rich collateral circulation. The main arteries that contribute to this collateral circulation are the genicular branches from femoral, popliteal, anterior tibial, and posterior tibial arteries. Similarly, the nerve supply follows a Hilton's law, which states that the nerves to the muscles crossing the joint also supply the joint. Hence, the chief nerves that innervate the knee are the femoral nerve, the tibial nerve, the common peroneal nerve, and the obturator nerve. Next, we come to an important concept called the Q angle, which needs attention. It is the angle formed between the lines drawn from anterior superior iliac spine to the midpoint of patella, and the other drawn from the midpoint of patella to the tibial tuberosity. Where these two lines intersect, it forms a joint which is called the Q angle. The normal Q angle in males is 11 to 14 degrees, and in females it is 13 to 17 degrees. And it is generally more in females because of the wider pelvis. Larger Q angles result in excessive lateral pull on the patella, and this can lead to patellar maltrachy. With this background of anatomy, now let us look at the biomechanics of the knee. The knee's movements are complex, which combine rolling, gliding, and rotation. The primary movements possible at the knee are flexion and extension. This extends from about 10 degrees of hyperextension to up to 135 degrees to 140 degrees of flexion. Some degree of rotation is also possible at the knee, especially when the knee is flexed. The medial rotation of up to 10 degrees is possible, and a lateral rotation of up to 30 degrees. A very particular movement called the screw home mechanism happens during the terminal 15 to 20 degree extension of the knee. This happens due to the medial rotation of femoral, because the medial femoral condyle is larger and longer and more curved than the lateral femoral condyle. During the final phase of extension, the tibia externally rotates in an open chain extension, that is when the foot is not planted on the ground, that is, it is in the air, or the femur internally rotates during this extension when the foot is planted on the ground. These movements help lock the knee, maximizing the stability of the knee while standing. This is responsible for lesser energy expended when a person stands for a prolonged period of time. And this is the reason why one can stand for prolonged periods of time without getting tired. The opposite movement to locking happens when the flexion is initiated, and this unlocks the knee for further flexion. Popliteus is the muscle which is responsible for this action. Another important function of the knee is load transmission. In standing, the medial compartment bears maximum load due to its alignment. The menisci, which are present between the femur and tibia, help distribute the force over the entire joint surface, thus reducing peak stresses on cartilage at the places where the bones are in contact with each other. During the gait cycle, the knee is primarily responsible for absorbing shock, providing stability, weight bearing, and also facilitates limb movement through flexion extension of the knee. And this allows for smooth, efficient walking or running motion. Many of these structures, like menisci, ACL, capsule, also have mechanoreceptors which provide a feedback to the muscles, enhancing their reflex stabilization during movements. Last but not the least, let's look at the patellofemoral joint mechanics. The patella increases the leverage of quadriceps by increasing the efficiency of its pull, by increasing the lever arm of quadriceps. In cases where the patella is to be removed, which is called patellectomy, this decreases the extension force of quadriceps by up to 30%. Hence, patella is a very important bone. The patella is stabilized by the congruence of trochlear groove, by the presence of medial and lateral reticula, and also, as mentioned before, the vastus medius obliquus muscle. The patellofemoral joint contact forces rise with the flexion of the knee. It is highest in squats and during climbing of stairs. This force can increase up to 7 times the body weight during squatting and up to 2 to 3 times body weight while ascending and descending the stairs. The patellar movement tracked along the trochlear groove smoothly, and any deviation in this muscle gliding movement is called the maltracking of the patella, which leads to patellofemoral pain syndrome. The vastus medius obliquus is the main muscle which stabilizes the patella and prevents the lateral displacement of patella. To summarize what we have learned till now, knee is a large synovial hinge joint. Its primary functions are weight bearing, force transmission, shock absorption, and enabling efficient locomotion through coordinated muscle ligament interaction. It permits flexion, extension, and slight rotation. The menisci distribute the load and absorb shock, while the ligaments prevent excessive translation and rotation, and these are aided by the surrounding muscles. Biomechanically, the knee transmits large amounts of forces during walking, running, jumping, and thus it balances mobility with stability. With this, I would like to conclude this lecture. Thank you and Jai Hind.